So first I want to welcome you all to Hip Dysplasia and Cerebral Palsy. My name is Mary Ann Girardi. I am the clinical education specialist here at Ultimate Medical. I am also a physical therapist. I've been practicing for 40 years, mostly with cerebral palsy and complex rehab technology. All right, as it said, I am an employee of Ultimate Medical. All right, we're going to start off with just a few definitions and some background information, just so we're all on the same page. The most current definition of cerebral palsy is a group of permanent disorders of development of movement and posture, causing activity limitations that are attributed to non-progressive disturbances that occur in the developing fetal or infant brain. It's important to remember that cerebral palsy is a disturbance in the brain that occurs anytime between the moment of conception to the second birthday. So children can have cerebral palsy diagnosis along with other diagnoses. So they can have cerebral palsy secondary to CVA or whatever. And sometimes it's very advantageous for them to have the cerebral palsy diagnosis, especially when it comes to accessing services and equipment, because it is an ICD-10 code that everybody knows. And it can be opened up where some of the less popular syndromes and diseases, you can get put into like a quagmire of trying to fight your way through the system. The other thing to remember about cerebral palsy is it's an umbrella term. So it covers all of these diagnoses and etiologies, but it's based on clinical and neurological symptoms. In 2017, there was a group of 41 clinicians who got together and developed a set of international practice guidelines. They did this through doing a systematic review of all the clinical practice guidelines available. They describe cerebral palsy as a clinical diagnosis based on a combination of clinical and neurological signs. One of the greatest things that came out of this systematic review and the new international guidelines is that you can now get a diagnosis of cerebral palsy or an interim diagnosis of at high risk for cerebral palsy can be made as early as 5 months corrected age, using a combination of history of risk factors, a standardized motor assessment, and neuroimaging. As I said before, it's important to get this diagnosis, but it's important to get it early because then you can access early interventions and interventions that are specifically designed for people with cerebral palsy. I think we all know the classifications of CP. It's classified via motor type, whether you're spastic, hypotonic, dystonia. It's also by topography, whether you're a diplegic with just your legs involved, hemiplegic, one side or the other, or quadriplegic, all quadrants of the body are involved. The other thing we need to talk about, or at least remember, is the GMFCS scale, the Gross Motor Function Classification Scale. This is a 5-level scale. It was developed in 1997, and it puts children into levels based on their gross motor function. And this is used a lot during diagnosing. It's also used a lot in research and to see what the future is going to be. If somebody's a level 5, they may probably stay at a level 5, but they can access more services. The GMFCS was expanded and revised in 2007, and it now contains an age band for 12 to 18 years old. What this means is now you can use the GMFCS for children throughout their childhood with cerebral palsy and have them in a classification level. The one thing to note, though, is that it's less precise for those under 2. So if you're classifying somebody who's under 2 years old using the GMFCS, you need to reclassify them at age 2 or shortly after that. We're going to be talking about hip dysplasia. So first, let's talk about normal pelvic development. In the first X-ray, you can see the normal pelvis of a 9-month-old. then an 11-month-old, and a 2-year-old. Through these, you can see how the bones are developing, the alignment's developing, and how the connection of the pelvis should develop in a typically developing child. We're at hip dysplasias when the head of the femur is not covered by the acetabulum or is not secure in the socket. There's many variations on this definition, but they all come down to you don't have the head of the femur securely in the acetabulum. So the first picture is a picture of a normal hip socket. The second is subluxation. If you can see, the head of the femur is lateral to the lateral border of the acetabulum. And then the third picture is a total dislocation. You can see that the medial border of the head of the femur is nowhere inside the acetabulum. The incidence of cerebral palsy is about 35% of all children with cerebral palsy have the risk of an MP, which is migration percentage, greater than 30% on an AP radiograph of the pelvis. There's a direct relationship between the GMFCS level 1 for 0% risk of cerebral palsy to a level 5, which is 90%. So the children who are more involved are more at risk of developing cerebral palsy, hip dysplasia. I want to make sure we all understand we're not talking about developmental hip dysplasia or congenital hip dysplasia. We're talking about hip dysplasia and cerebral palsy. And the main difference is that children with cerebral palsy are born with normal hips. Their skeletal hip alignment is normal. The displacement occurs as the child grows, and it's directly related to the GMFCS level. If you're doing literature searches, hip dysplasia is also known by cerebral palsy hip dysplasia, spastic hip subluxation, hip subluxation hip displacement, neuromuscular hip displacement, neuromuscular hip dysplasia, hip dislocation in CP, and hip lateralization. The current trend is going towards using the universal term of neuromuscular hip displacement. And that's the reason, because in the early days, when they were first starting to look at hip dysplasia and hip dislocations in cerebral palsy, they thought it was only due to spastic muscles. They've found out that it is also occurring in children who have hypotonia. But if you're trying to do a literature search, you're going to have to use all these names. So is hip dysplasia is the underlying dynamic muscle imbalance occurring in the setting of the growing hips, results in a distinct pathoanatomy of both the proximal femur and the acetabulum. And that's important to realize, that it's not just the head of the femur that's laterally moving out. There are changes in the acetabulum and the makeup of the head of the femur. It includes both, which is what makes up your hip joint. The gold standard to diagnosing hip dysplasia is Reamer's migration percentage. And what Reamer's is the percentage of the of the head of the femur that's lateral to the acetabulum. You can see here, here's the lateral border of the acetabulum, the lateral border of the head of the femur. And that's the migration percentage, the percentage of how much the head of the femur has come out from underneath the acetabulum. Subluxation is considered to be greater than 33% of a migration percentage, and dislocation is considered to be greater than 40%. In some of the literature, you'll see it, they consider subluxation to start at 30%, and some don't consider dislocation till 50%. A way to calculate the risk of the child that you're working with's risk of developing hip dislocation is the CPUP hip score. It's an app you load up on your phone. It was developed through the CPUP program in Sweden, which we'll talk more about later, but they're the leaders in hip dysplasia and hip dislocation and prevention of it. You bring up the app, and then you fill in the GMFCS level. You fill in the head shaft angle, which is the angle between the shaft of the femur and the head, where the top of the head is. The migration percentage, and then the age of the child. And it will calculate the risk score of this child having a dislocated hip. And in this case, with these values, there's a 50 to 60% chance that the child will have a dislocated hip. The risk factors, the strongest one is GMFCS level. It's a linear relationship between the risk of developing hip dysplasia or migration percentage greater than 30 or 33%. In some places, they call it the migration index. As you can see, GMFCS level 1 has a very low risk, where GMFCS level 5 has a big risk. Think about the differences between 1 and 5. Once you get to 3, you're not up and walking, you're not weight bearing, less and less, you're not full time, and it increases until you get up to GMFCS level 5, when you're pretty much not weight bearing at all and standing. You're weight bearing through your pelvis, but not through your lower extremities. The children in GMFCS level 1 and 2, if they have the Winters Gauge Hicks gait type, it increases their risk. And what the Winters Gauge Hicks gait type is what you would expect as your typical hemiplegic gait. Hip and knee flexion, internal rotation, adduction. And what that does is it takes the head of the femur and rotates it to a point where it's not as covered by the acetabulum and is at greater risk to sublux or come out. Another risk factor is age. If you see, the peak of when the hip reaches 30 to 33% is between 3 and 5 years old. And the peak of dislocation occurs in 5 to 6 years old. But if you look closely, you can see that kids reaching the MP of greater than 33% can happen before their first birthday. There was a study that showed that a high proportion of children actually dislocate before the age of 2. So this just further reinforces that we really need to do intervention as soon as possible, get that diagnosis of CP or at high risk for CP, and start intervention so that we don't get hip dislocations. Another risk factor is the rate of the increase of the MP. If a child's migration percentage, or MP, increases more than 10% within the last year, the risk of dislocation also increases significantly. How an MP increases is directly related to the GMFCS level, so 0.2% per year for level 1 to 12% per year for level 5. The average increase in MP can go up to as far as 12% in level 5 per year. One study showed that an increase of 8.2% in those children under 5 years old, and then 4.4% per year in those children over 5 years old. There's been a study that shows that when you're younger and under 5 years old, when your body's doing all of that development, all of that growing, the MP can increase significantly and quicker, and it happens at a faster rate. Once you hit about 5 years old, the rate of migration decreases, and this study actually showed that if you can keep the MP under 33% till their 5th birthday, the rate of dislocation significantly decreases. Another is the head shaft angle. The head shaft angle, which we talked about, is the angle from the femur to the shaft, the head. It typically decreases in typically developing children about 2% a year. So what happens is they get up and weight bear, and the forces from weight bearing take the head of the femur and slowly decrease that angle, so the head of the femur is going to fit into the acetabulum securely. They found out that with CP, it decreases less than 1% a year. And they found out with GMFCS level 4 and 5, they don't change at all from birth to when they're 5 years old. Again, they're not weight bearing. Remember, 4 and 5 they don't really walk a whole lot, and most of the time they're dependent for mobility. They're not getting up on their legs. They're not doing the weight bearing and putting the forces on the bones that need to be done. At age 2, a head shaft angle greater than 174 degrees may be a predictive of dislocation. But after 2 years old, that's not an indicator. I actually just read a new study yesterday that says the head shaft angle is not a predictor for children over 2 years of age. So we can actually classify hip dislocation, hip dysplasia. The Melbourne Cerebral Palsy Hip Classification Scale was developed in Australia. It's a radiographic classification of 6 grades, starting at a normal hip, a hip that's totally intact, covered well, the acetabulum covers the femur well, to grade 6, which is a salvage surgery, which is after the hip is dislocated and they're trying to repair it. We'll talk about that a little bit later. At skeletal maturity, these were done, which is approximately 14 to 18 years of age. You need to be aware of there are some syndromes and conditions and other things that delay skeletal maturity. So you're really not going to hit skeletal maturity at 18 years old. It may be 21, it may be 22. And actually the pelvis doesn't finish ossifying until your 20s. So even you've got maturity 18 to 20, it could be longer before the cartilages in your pelvis are totally ossified. We also want to talk about hip surveillance programs. These programs are the process of monitoring and identifying the critical indicators of hip displacement. The goal of these programs is to prevent hip dislocation. The goal of monitoring children with cerebral palsy and measuring their migration percentage is to prevent hip dislocation. A hip surveillance program is the clinical and radiographic examinations that happen on intervals based on the GMFCS level. The clinical exams are usually done by an OT or a PT, and they include range of motion and pain, especially if there's pain on abduction. You want to note that. They confirm the GMFCS level. GMFC levels can change as the child gains motor skills, they will move into the levels. Or if the level they were classified before the age of 2, it's going to change after the age of 2. You have to determine if they have the Winters gauge Hicks, which is that hemiplegic gait, because again, that takes the head of the femur and it moves it out of the central location of the pelvis, of the acetabulum, and is more prone to dislocation. There's a radiographic exam. These children have x-rays on a schedule based on the GMFC and their age. And from that x-ray, they're going to measure the MP. They found that the x-ray has to be in a standardized supine position. And in the handouts, there's a picture of what that is. Because to get consistency in the MP rating, they were finding differences if they were just a little rotated, if the pelvis was a little anterior. There was a difference and it wasn't giving the true picture of the hip displacement. So they've determined a specific position, which the radiograph is taken, and then you can determine the MP. Surveillance programs are important because they identify those at risk of hip dislocation. The schedule exams will monitor. Remember, if it progresses more than 10% a year, you're at a higher risk for dislocation. So you want to monitor the changes in the MP over the years. And also it enables timely intervention to prevent the hip dislocation. This intervention can be surgical, can be PT-OT, can be bracing, can be standing programs. And why you want to prevent the dislocation is because hip dislocations lead to secondary impairments such as pain, arthritis, decreased range of motion and function, and decreased quality of life. And if we can prevent any of those, it's our duty to do it. There are national surveillance programs, and these are mostly in Europe. Well, the original one was in Sweden. It was started in 1994 in the southern part of Sweden. And in 2007, it became a national program, and now it's pretty much across Scandinavia. These children are picked up as soon as they have a CP diagnosis or at risk. The latest the first x-ray should be done and exam should be done is 2 years old. The Australian model was developed between 2006 and 2008 based on the Scandinavian CPUP model. And they revised it in 2014 because they realized that they weren't capturing the data they needed to identify those at high risk. British Columbia has a model. It started in 2012, and it's based on the Sweden and Australia outcomes. Hip surveillance in the United States. We don't have a national program. In 2016, the Pediatric Orthopedic Surgeons of North America sent out a survey to their members. And of those that responded, only 20% of the pediatric orthopedic surgeons were engaged in doing regularly exams and x-rays of their patients with CP. But they did find that 90% of them would follow a regular schedule if it was available. So Posner worked on to develop it. California Children's Services is the only statewide program that I'm aware of. If you know of one, please email me. And it's a voluntary program, and it's usually initiated by a therapist it should be in your handouts. There's a form they fill out when somebody's at risk, and they refer them to be reviewed by the clinical team to see if they need to be forwarded for an x-ray. The American Academy of Cerebral Palsy and Developmental Medicine published a care pathway in 2017 to provide recommendations for hip surveillance programs in the United States. The Pediatric Orthopedic Surgeons of North America published their screening guidelines in 2021. So this is a picture of the American Academy of Cerebral Palsy and Developmental Medicine's care pathways. As you can see, there it is, age down, GMFCS level, and these little icons say whether at that time they need a pelvic x-ray, a clinical exam, both, and how frequently they need it. Again, the latest that first x-ray should be done is 2 years old, but if you can get it done as soon as they have a diagnosis of at high risk for CP, you've got your baseline and you can start your interventions. Positives is about the same, again, based on age and GMFC level, and they're going, again, whether you get an x-ray 6 months a year, 12 months, every 3 years, most of these will go until age 8 because they figure the risk of hip dislocation decreases after age 8. But you should continue to monitor them longer, especially if they haven't reached skeletal maturity. There's a tool that was developed which helps both primary care physicians, parents, therapists, anyone who wants to learn about hip surveillance. And it was developed by 2 orthopedic surgeons at Shriners Hospital in Sacramento, California. And they developed it so that people would have a resource to understand what hip surveillance is and how to implement it. It's really easy. It's an app that you download onto your phone, contains a ruler, and there also are instructions on the app. In case you get lost, you can hit info and it will guide you through what you need to do next. You upload the x-ray, and then you level the x-ray according to these lines with bony landmarks, and they give you a series, I think, 3 to choose from. Then you're going to add the ruler to the x-ray. Then you're going to enlarge the x-ray so that the medial border of the femoral head is against the black line. The lateral border of the femoral head is against the white line. If the lateral border of the acetabulum is anywhere within this red box, the hip migration percentage is greater than 30%. As you can see, there's a right and a left ruler. I think this is a really good app. We all get our x-rays digitally now. If you're working with a child that you're concerned about, you can pull this up. It's not a diagnosis, but you can get an idea of what their hip status is and where it's going. So how do we manage hip dysplasia? Well, we have non-surgical management, which includes Botox and bracing, postural management, and standing. So for Botox and bracing, remember the early days, they thought it was only spasticity that caused hip migration and hip displacement. So the goal was to address the spasticity. Let's stop the spasticity, and that's going to stop the hip migration. So this was a randomized controlled trial of 90 children. The treatment group got Botox injections to the adductors and hamstrings every 6 months for 3 years, and they wore a swash brace for 6 hours a day. A swash brace is an abduction brace. It keeps the lower extremity in abduction, but it's free flexion extension at the hip. The control group had no injections or bracing. How they determined their outcomes was a serial measurement of MP. And what they found was the rate of displacement in the treatment group reduced by 1.4% a year. So in this case, the combination of the Botox and the bracing was able to decrease it a little bit. Postural management is a treatment designed where external supports are used to maintain symmetrical alignment 24 hours a day. They manage alignment in sleeping, sitting, and standing. I think if you want some good resources in the United States, Posture 24/7 website is an excellent resource on postural management. It started over in England in the late 80s, early 90s, and one of the early hospitals to adopt and develop it was the Chailey Heritage Hospital, and they developed their own positioning systems. This is their sleep system. They also have developed the Chailey levels of ability. For those of you who are working with low functioning children, look up the Chailey levels. It's a good eval that you can actually document progress. You can document their status. For kids who don't really have a lot of gross motor function, it's a good place to start. So they did a retrospective study. It's a residential facility of 59 students, 40 those who participated in postural management, including lying, sitting, and standing, and those that didn't have postural management. And what they found was that 43% of the participants that participated in postural management, the 24/7 positioning, their MP stayed under 33%. And that's the goal. Keep the MP under 33%, at least till age 5, if not longer, because most of the migration is going to happen before age 5. And there was a study done, again, out of CPUP in Sweden, that after age 5, the rate decreases and hips stabilize. So if you can keep them under 33% till at least 5 years old or 6, you've got a good chance that you're not going to dislocate. They did find that 53% of the participants who didn't use postural management ended up with MPs greater than 33%. Greater than 33%, you're on subluxation, and you're headed towards dislocation, which is 40 to 50%. The Chailey Hospital also did an earlier study in 2002, and what they did was they looked back at 39 students who started using postural management under 18 months of age. They x-rayed them at 30 and 60 months to check the migration percentage, and they compared it with the incidence of migration dislocations that they had had from prior years. And they were able to determine that an 18% reduction in hip problems was achieved by using postural management. So it's something to think of. I know trying to get sleep systems paid for is difficult at best, but if you go to Posture 24/7, they show you how to make them out of pool noodles. And you can get those at the dollar store. Your seating, everybody gets, and we'll talk about standing. Another study was a systematic review of postural management. 7 out of the 8 studies showed that it had a positive effect on reducing hip migration after postural management interventions. What I found very interesting was you looked at the pictures from that 8th study that said that postural management had no effect on migration percentage. And you'll see that they used what's called standing shells, which are either made out of plaster of Paris or like brace material plastic. But if you look at the pictures in the standing shells, none of them are in abduction. They're all in central alignment, straight up and down with the hips. The systematic review could not make strong recommendations as to the use of postural management because of the low quality studies. We hear this all the time. Most of the research studies done on children with cerebral palsy, as far as therapy interventions, are low quality because either they have a small sample group, they don't have a randomized controlled trial because, in my opinion, am I going to keep treatment that I know can make an effect or could have an effect from a child just so that I can get the data to do a study? Ethically, I can't do that. But you find that through all of the studies on treatment, especially in standing and NDT, any of them. If you look at Novak's traffic light system, postural management and standing are a yellow light, which means there's some evidence. It's not going to hurt them, so try it. I think one of the ways to change this is if you're working with children with hip dysplasia or MPs, you've got them in standing, and you can do a case study that shows that standing is an effective intervention. Send it to me. I'll keep it with us. But the more case studies we have, the more, as they call, anecdotal information, the better the evidence is going to be and the more accepted it will be in the future. We're going to talk about standing, because standing is the one thing I have actually heard 2 orthopedic surgeons say it is the only intervention that has any level of evidence to help with migration percentage decreasing. So mechanical loading is necessary for healthy bone development. The weight-bearing surfaces and the loading of the muscles stimulate the bones to grow and the architecture. So with the weight bearing, you got it up there, you're going to bring the head shaft angle and the acetabulum is going to fit. It also helps with bone density, though children with nutrition and hormones, and especially the anti-seizure meds, have issues with bone density because they're not getting enough vitamin D and calcium. It has been suggested that a lack of weight bearing combined with abductor insufficiency cause primary deformities of the proximal femur leading to hip displacement. You're not getting the weight bearing, the femur's not forming. And why is weight bearing important? Because of Wolff's Law. Wolff's Law basically says the bone is going to adapt in composition and architecture based on the forces that are applied to it. So you find with CP children, their long bones tend to be pencil thin and brittle and short. CP kids don't grow as tall as other kids, especially levels 4 and 5, because they're not weight bearing. They're not putting the forces on the bone to stimulate the growth and the development and the architecture to get what you need. So when you're in standing, you've got your femurs like this, your acetabulum's here. In order for the acetabulum to develop and the head of the femur to develop, there needs to be weight bearing and remodeling happening, in addition of bone growth. I remember years ago, I worked with a child with cerebral palsy who'd never bared weight on his legs in his life. He was 10 years old, and the first hip x-ray I saw of him, his femurs were perfectly straight. There was no angle. We had hit bilateral hip subluxation and pretty close to dislocation. That was my first experience with a swash brace, and they are wonderful. Yes, they are. Let's get rid of them. So what standing can do is they did a study, you're going to get them up in weight bearing. You're going to get the forces on the bone from the gravity, and you're going to get the bone to develop like it should be developing, because without the forces, there's no reason for it to get stronger. There's no reason for it to change its architecture because it's not doing anything. It's perfectly fine. You're weight bearing on your pelvis. You're not using your legs. You don't need any changes in the femur. So this study was one of the first ones done out of Spain. The treatment group stood for a minimum of an hour a day in abduction from age 12 to 14 months to age 5. The control group did no standing. They considered the results by the MP remaining stable at 13 to 23% in the standing group, where the control group that did no standing, the MP increased to 12 to 47%. The conclusion was that early standing, especially below, again, got to get them early, before the age of 5, while the bones are developing, the architecture is developing, and it can enhance acetabular development. Another study was done, and this was a retrospective study of 269 children, all 4 and 5. Most of the research being done is being done on the children in level 4 and 5 because they're the ones with the highest risk of hip displacement. They're also the ones who don't stand. They don't weight bear. So they also tested those who had had surgery. They stood in 30 to 60 degrees of total leg abduction for 10 hours a week, a minimum of 10. Some stood a little bit longer. 30 to 60 degrees of total leg abduction is 15 to 30 degrees on each side. When you have a wee one, 60 degrees of abduction is a lot. It may be painful, so you don't want to put them into abduction past their comfort level. You also need to know when you're putting child in abduction, when you're bringing the leg out to abduction, you need to keep an eye on the pelvis, because if they have a limited range of motion, either from bony because of the subluxation or because of muscular tightness, that pelvis is going to rotate to give you the abduction. It's an optical illusion. So you want to keep the pelvis level and get them out to as much abduction as physically comfortable for them and they can tolerate. If they're going to be standing there an hour a day, 10 hours a day, it doesn't have to be done all at once. It can be done a half hour here, a half hour there, as long as it adds up to 10 hours a week. Most of the people I've worked with stand from 1 to 2 hours per day in abduction. In this study, the control group only stood from 0 to 20 degrees of total leg abduction for the same total amount of hours a week, 10 hours a week. They followed these children up for 7 years to see if anything changed in the 7 years. What they found was the median MP decreased 7% in the test group without surgery and 3.5% with surgery. The reason for the decrease of the MP decrease with surgery is once you get the surgery is going to give you an immediate MP decrease because you change the architecture. And this is what they had after. What they found in the control group, they were standing. They were standing for 10 hours a week. They should be fine. They were only in a maximum of 20 degrees of abduction. And they found that the MP increased 6.5%. Standing after surgery decreases the MP 18%. The thing to remember is that just because you had the surgery doesn't mean you're done. The hip can still resublux or dislocate after surgery, and being able to maintain the standing, again, doing the weight-bearing forces through the pelvis and the head of the femur, keeps that head of the femur covered and decreases the MP. So why abduction? It's all physics. I know I hated physics in college, but I'm glad I took it. When you stand in neutral, the weight-bearing forces are going more to the lateral rim of the acetabulum. It's giving the force to more make it shallow or come out, or for the hip to come around. When you put the child into abduction, the 30 degrees of abduction, you get that head of the femur centrally located in the middle of the acetabulum, providing the stimulus that the bones need to grow and form around the acetabulum. It's important that the head of the femur needs the shape of the acetabulum to develop its shape, and the acetabulum needs the head of the femur in contact to develop its shape to be effective. Wolff's Law takes over and we're getting good hips. The other thing to remember is when you're putting a child in abduction, you need to check that alignment. because some standing devices, the way you get into abduction is you slide the foot plates out. And what ends up happening is the angle at the ankle, because you've got a foot plate that you were perfectly level here, you slide it out here, but the hip's still over there, so it's going to rotate. And what that does is it's going to change the forces going into the pelvis. So if your child has that type of stander, you're going to want to put a wedge under the medial border of the foot. You want to get the foot perpendicular to the tibia. So why do you want and how do you design a standing program? You need to stand a minimum of 5 days to get effects. 7 days is better. For hip stability, it's a minimum of 60 minutes a day and 30 to 60 degrees of total abduction. For range of motion, it's 45 to 60. These children with spasticity tend to get hip and knee flexion contractures and ankle plantar flexion contractures. It's been demonstrated that standing 45 to 60 minutes a day in a stander with weight bearing can increase range of motion in the first place because it's a prolonged stretch over a longer period of time, and it can maintain that as long as they continue the standing. There was a study done here in Boston long time ago at one of the residential schools, and they had great results with kids in standers. They got the hip extension, they got knee flexion contractures under control. They sent the kids home for vacation. They came back and they had lost range of motion. Those of us who work at schools where kids come in and out, it always happens. They go home and they lose skills. So it's important to maintain the standing daily, no matter where you are, and especially for the little ones. And the stander on the side is the Zing Portable. I recommend you go to our website and look at it. It's for wee ones and it folds up and you can transport it. So take a look at it. The other reason for standing is spasticity. They showed that 30 to 45 minutes standing a day decreases spasticity. If we can decrease spasticity, we can get a better stretch on the joints and increase range of motion. The reduction in spasticity is only going to last about 35 minutes after. There's no carryover. So again, it has to be done daily. And standing 60 to 90 minutes a day will have a positive effect on bone density. All right, going back to the hip dysplasia, we want stronger bones. We want bones to develop. A standing program of a minimum of 60 minutes a day, 5 days a week, I'd prefer 7, will give you increased benefits in all of these areas, which will help the function of the child. Surgical management. It's divided into 3 categories: preventative, reconstructive, and salvage. In the early 1990s, especially out in the San Diego area, it's actually called the San Diego approach. Orthopedists felt there is no way to prevent it. Once the hip starts to migrate laterally, that's it. It's going to dislocate. You can't prevent it. But I think we've changed that now. With the preventative surgeries, they're done when the MP is greater than 40%. So you're heading towards dislocation, you're past subluxation, or you have a 10% increase in a year. Remember we talked about if the migration percentage increases more than 10% in a year, that hip is moving quick and it's going to dislocate. The other indication for preventative surgery is a hip abduction of 30 degrees or less. It means you've already got a block there. They're going to go in and try to fix it. It's either usually from spasticity or it could be a bony block. So the preventative surgeries are selective dorsal rhizotomy, soft tissue releases, and a hemiepiphyseal guided growth. Reconstruction is done when the MP is greater than 50%, early dislocation, and you're starting to get degeneration of the femoral head. Remember, the hip moves out. Instead of being in that nice little center of the acetabulum, it's on the edge, and you're going to get bony degeneration of the head of the femur and the acetabulum. And these include femoral varus derotation osteotomies, pelvic osteotomies, and a combination of both. And salvage surgeries, they're the last straw. That's it. This is when the hip is dislocated, it's painful, there's degeneration in the joint, or you've had one of the other reconstructive surgeries and it failed and you dislocate it again, which is very common. And these include proximal femoral resection, valgus osteotomy with femoral head resection, hip arthrodesis, and replacement arthroplasty. So let's talk about SDRs. This was a retrospective chart review. They included all of your GMFCS levels were included, and they found that the MP prior to the SDR surgery compared to the MD post the SDR surgery. And what they found was the incidence of hip displacement with children who had had the SDR didn't differ from the overall incident you find with children anywhere in CP, whether they've had the SDR or not. So it's not really giving you a whole lot. Doesn't mean it won't give you better function if you've got somebody walking, if you've got less spasticity. So soft tissue releases, tenotomies of the adductors and the iliopsoas. As I said, I've been a therapist for quite a while, and everybody had adductors, psoas, hamstrings, everything, gastrocs. Kids had surgical scars everywhere because it was just done routinely. You had spastic CP, whoops, you get these. So they found that they did the surgeries at a mean age of 5, and they considered a good outcome if there were no further surgeries or the MP stayed less than 50%. The results of their study were all of the ambulatory children and 17 out of 28 of the non-ambulatory had good outcomes. Are we seeing the theme here? If you're up and walking and weight bearing, you've got a better outcome, you've got better hip formation. If you're non-ambulatory, the surgeries are not weight bearing, the results aren't as good. The other thing is you need to do the soft tissue surgeries before the MP reaches 50%. Once the MP reaches 50%, the hip is just on a fast road to dislocation. So if you wait until it's 50%, it's not really going to do much. The hip's already there. The architecture of the hip is already changed, and the intervention with the muscle length isn't going to help the dislocation. The guided growth procedure. This is a fairly new procedure. The first article I found written about it was in 2010. It had been used previously for severe knee flexion contractures to reorient the distal end of the femur. So this was a systematic review of 4 studies. There were 93 patients, 178 hips. Remember, when you're looking at studies, that not everybody dislocates on both hips. So you could have 100 patients and only have 125 hips looked at. Just something I find interesting, in that you need to look at it when you're looking at the surgery. So they did 2-year follow-up. They had mean MTP changes of 8.48%, the head shaft angle of 12.28%, and the acetabular index of 3.41%. I didn't talk much about the acetabular index today because it's not considered a really good indicator for hip dislocation anymore. The MP is the best measurement and indicator. So they performed the soft tissue releases, and at the end, they were also performed with the guided growth. At the end, they found it was an effective measure, but they caution, because this is a fairly new use, they really haven't determined the best techniques, the best timing of the surgery, and who are the best candidates. So it's something out there, but it's not, if you're looking at the traffic light system, it's down on yellow. It's not green, but it's not red either. A femoral varus derotation osteotomy. So again, what we want is alignment. We want that head of the femur to be firmly in contact in the centrally located acetabulum. So they go in and they make 2 cuts. They reorient the head of the femur. So the head shaft angle was here, and now they're going to bring it down here, and they internally fixate it. This was a study done in Boston. They did 570 VRDOs and 320 children. They were 8.2 years age mean, and they followed up for 8.3 years. They had a 37% failure rate of this surgery. So over a third of the children that had the surgery, it didn't work. It failed. They had to be reoperated on again. And what they attributed it to was the younger age. They found that if they operated on the younger children, there was a higher failure rate. The problem is that the hip is going to continue to grow. Just because you've done the operation, you're not going to stop the growth of the pelvis. And if the spasticity is still there, it's going to just come back out again. And also the GMFCS levels. So your levels 4 and 5 have a worse rate. So the surgeon who did this is like, the children who need it the most because their hips are subluxed or dislocated have the worst survival rate. There was no information on whether standing was included after the surgery. I tend to think not. Combination of VRDO and pelvic osteotomy. This is where they're going to go in, put a wedge in the pelvis, which you can see right here. So we're going to bring the roof of the pelvis down to meet the head of the femur. We're going to bring the head of the femur over to meet the center of the acetabulum. So we have good alignment. It's good centrally located. So they studied the VRDO alone, which is just doing the head of the femur, or a combination of both. Out of 39 hips, they had good outcome in 29 hips and poor outcome in 10. They associated the higher outcomes were when you did both the pelvis and the femur, but it wasn't statistically different. So somebody asked me what somebody in abduction looks like at the morning seminar. So this is my friend. If you notice, she's in full 60 degrees of abduction. You can notice her feet are in good alignment with the tibia, and she's happy. She's actually a child that I know, and she was recommended to have surgical intervention because her MP increased over 10% a year. Her mother researched to find other alternatives and heard about standing. She's a GMFCS level 3, so she was a partial ambulator with a posterior walker. She started a standing program of 2 hours a day, 7 days a week. 6 months, the MP remained stable. It didn't progress anymore, and in a year, surgery was off the table. Salvage surgeries. Sorry. They did a systematic review. Remember, the salvage surgeries are when the pelvis is very painful. The hips degenerated, the joints degenerated. So they did the femoral head resection, the valgus osteotomy, and the total hip arthroplasty. They found that they had better pain relief with the total hip arthroplasty, better than the arthrodesis. The problem is they're associated with complications. The femoral head resection had the lowest percent of complications. Surgically, one thing to remember with the femoral head resection is I've worked with adults who've had this done, and they tell me they feel like their legs are constantly falling off because there's no bony attachment anymore. It's only the muscles. And with younger kids, it's kind of scary. So you may want to work on that and just keep that in mind when you're working with them. Again, non-ambulators had the worst complications. The arthrodesis in non-ambulators was 100% complication. I think that's a typo. The ambulatory patients had excellent pain relief with the total hip arthroplasty, but the complication rate was higher than non-neurological. Again, cerebral palsy patients have other comorbidities. They're not your normal granny walking down the street getting a total hip. So there are more complications. They did another study on salvage surgeries, which I think this is important to know that it does help. Remember, they're very painful. The children were 12.2 years old. They followed them up in 56 months. They gave them the Caregiver Priorities and Child Health Index of Life with Disabilities and the Pediatric Quality of Life Inventory. Of all 37 patients, they had significant improvements on both of these measures. Again, salvage surgeries, when it's the worst, it's so painful, it's interfering with your day's activities of daily living, it's interfering with your life. So you do the surgery, you repair that, you relieve the pain, you have a better quality of life. They actually did an odds ratio on whether you would need to have another operation or reoperation, or if the hip was going to resublux again. They found that the odds ratio for a combined pelvic osteotomy and femoral osteotomy was 0.49 for resubluxation or reoperation. For soft tissue, it was 0.2. And for pelvic or femoral, not together, it was 2.27. So the odds of having to have the surgery again are fairly high, especially if you do it young, because the body grows. And there's an article by David Johns that goes into it really good about the changes in growth and what that does to the surgical site. It's in the references and you can find it online. I think it's a free article. They also studied in the study the change of MP. So when you had the combined pelvis and femoral osteotomy, you had a 60% improvement in MP. Isolated pelvis was 45%, isolated femoral was 33%. Soft tissue, you had a 10%, but they found no significant improvement in Botox alone. So addressing the spasticity alone isn't going to help. So why is hip health important? It's for quality of life. They found, this is a quick study, I know we're running out of time, that they found a linear relationship for every degree or percentage of migration percentage increase. There was a decrease in the quality of life score by 0.188%. We need to maintain it. These kids are 10 years old. Their quality of life is decreased because their MPs keep increasing and the pain hips interferes with their ability to be dressed, their ability to turn over, their ability to function. I found this very interesting. Hip dysplasia is the most common cause of arthritis before age of 50. And that's just not CP kids. That's for everyone in the United States. So some of these are congenital hip dysplasia, some are CP. It's responsible for 5 to 10% of all the total hip replacements in the US. Think of how many are done every year. And 5 to 10% of them are because the patient had dysplasia. If we can prevent that, I think we should. I found this study really interesting because it was a study on 18-year-olds. 72% of them reported pain, but they also looked at whether they were involved in hip surveillance or no hip surveillance. And also they used the Melbourne CP hip classification scale, which shows the severity of the hip. So people who had a grade 1 to 4 hip score, their pain severity was only a 2. But once you get to 5 to 6, and remember 6 is salvage surgery, these are the kids, or adults in this case, whose hip needs to be repaired. It's just painful, it's degenerative. Their pain score was 7. You can also notice that those that were in hip surveillance had less of, there were less, but not a lot, going down to level 5 and 7. So it was hard. There was only 9 kids without hip surveillance. So why is this important? Hip dysplasia occurs in 1/3 of all of the children with CP, those that are ambulating and those that are not. Remember, those with the hemiplegic gait are more at risk, but children level 3 who are not full-time ambulators. I read a study that said you have to be weight bearing 6 to 7 hours a day. I think that was an exaggeration, but you need to be up and walking. You need to be weight bearing. If you can't walk, you need to be up and weight bearing. The risk is directly related to the GMFCS level. The higher the GMFCS, the higher the risk. Frequently, there's no symptoms. There's no pain. The little girl I showed you had no leg length, no glizzy, no pain, no range of motion limitations, but had a migration percentage of 40%. The peak occurrence is 3 to 5 years old, so we need to get them younger. We need to get the interventions to them younger so that the hips don't displace and they don't go to dislocation. Standing 60 minutes a day, 5 to 7 days a week, in 30 to 60 degrees of abduction. Remember, the abduction is important to get the head of the femur where it needs to be in contact with the acetabulum, and in the center of acetabulum to get it, the bone to grow, stimulate the bone to grow and cover the acetabulum. You can start standing as young as 9 months. I think it's important that typically developing children pull to stand around 6 to 9 months. It's important that we provide the same experiences and the same stimuli and input to the skeletal system to enable it to develop. So starting at 9 months is key, or as soon as you can. It's important to have a hip surveillance program. Most of the local larger children's hospitals have one. If not, try to find somebody, get yourself the hip screen. They need to have that first radiograph at the latest at 2 years of age. If they're diagnosed at high risk or CP prior to that, get them to get the radiograph in the standardized position so that you can get the MP measured. It's important to keep the regularly scheduled exams so that you can monitor and make sure the MP or the increase in the migration percentage is in an acceptable level. It's not 10%, it's lower, and that we keep it below. And it can help prevent dislocation. The CPUP program in Sweden is the best example of this. They started in 1994. Within the first 5 to 10 years, they were able to decrease the occurrence of hip dislocation for cerebral palsy children in Sweden from 10% to 0.4%. They've been able to maintain that for over 25 years. If we can get it on a hip surveillance schedule and we can get it integrated into more programs, then maybe the salvage surgeries don't even need to be in the books anymore. Or we can keep the kid comfortable and functional. They say from Sweden, if you can keep the MP under 33%, you can live a normal life. It won't interfere with function and it won't be causing pain. So our whole goal is to keep them under 33% until they reach skeletal maturity. Let me look at the questions. There seem to be a few. No, we do not have parapodiums. But we do, Ultimate does have the Zing portable for children under 2. It's not as bulky and it weighs 30 to 40 pounds. It folds up and you can fit it in the back of your trunk. The PDF was in the chat box. If you didn't receive it, email me and I will email them to you tomorrow. The website for postural management is 24/7, posture247.com. Again, email me. You can Google postural management. And I'm blanking on her name. Tamara Aldrich. Email me and I'll send it to you. The levels are the GMFCS or the gross motor functional classification scale levels. When they're in 24-hour positioning, you're trying to get at least 15 to 20 degrees of abduction. The study, can you put the name of the assessment in the chat? I will send that to you. Or email me and I'll just send you a copy. My email's at the end. If you email, I'll send you a copy of the Chaley levels. It's Chailey was the name. It's not chili, it's Chailey. Actually, if you go to our website and go under courses, there's a course I did earlier in the year called Preventing Deformities, Early Positioning is the Key. And that it's all on postural management. It's all on the Chailey and the posturability and positioning scale. But if you just want the documents, email me and I'll send them to you. Again, email me and I'll send you the devices. Gretchen asks, what percentage of hip development is from active weight bearing as opposed to inactive passive standing? I don't have the answer for that. I will look and see if I can find it. I think what you're doing is going along the lines of bone mineral density, where they show that intermittent can produce more, but I'll look it up and see. Gretchen also asked, at what angle does a child need to stand and bear weight to get the effectiveness of hip development? Reclining decreases the amount of development. You are true, but even when you're up and not in total vertical, of course, total vertical, you get the most. But even when you're out a little bit in supine or prone, you're getting stimulus in weight bearing, though it's not full weight bearing of their whole body weight, through the hip joints, which in contrast, if you're sitting in a chair, you're weight bearing on your ischial tuberosities, and most kids the sacrum because they posterior tilt. What if the child is very limited abduction due to strong spasticity? How can you put the child into standing abduction? I would start with as much abduction as you can get. Remember, standing and prolonged stretch increases range of motion, decreases spasticity. I would hope you put them in as much as comfortable, and I would hope that as they stand and gain more range of motion, you can move them out as needed. That was they said, what did you say about getting rid of the swash braces? Do you recommend them or not? They serve a function. I apologize. That was a personal commentary. I don't like them, but I think that they have a place, especially to keep kids in abduction at all times. And I withdraw that we should get rid of them. They have a purpose. I just personally, I've had such poor experiences trying to get kids to wear them and to get parents to put them on. And that was my personal opinion and should be labeled as such. Have I seen an increase in 24-hour positioning, and how involved are you with this? I have seen an increase in this country. I try to do it as much. I've actually, my whole career as a PT, I've used positioning. As I said, I've been a PT for a long time, and I worked in an institution, and none of these things were available. We used to build it. We actually used to take foam and hand carve it to make side liers, to make supine positioners, to make prone positioners. I think providing a child who has the potential to get deformities, again, go watch the other seminar, if we can keep them in alignment and prevent the shortening from happening and the changes in the skeletal, again, because of Wolff's Law and because the way the muscle reacts to stretch and position, the use of positioning is helpful. And it's hard to do it. And I go read the course, go see the other course, or email me and we can talk about it more. It's a huge topic. Even if they have are you recommending standing programs still effective for those diagnosed with hip dysplasia after age 6? Yes, because unless the hip is totally subluxed, you can affect the migration percentage. Once you get up to about 13, it says, what product would you recommend for a 13-year-old for school use? It depends on the transfers. Carla, if you don't mind emailing me so that I can find out a little bit more, and I'll let you know which one. The handouts were in the chat. If you didn't get them, email me, and my email address is on the screen. I will send them to you tomorrow. Ultimate currently is working on standing, and we're not working on providing products for sleeping or sitting. I think there's a plethora of sitting out there. Just look at Swiggles, all the other wheelchair seating. We're presently not working on developing devices for 24-hour positioning. But if you go to the Posture 24/7, they can be easily made out of pool noodles and teddy bears. The upper age is there an upper age when standing and hip abduction no longer affect the hip development? It's around 8. But the standing is still good to help with range of motion, bone density, everything else. I didn't see the tram. Yes, Medi-Cal does cover standing equipment. I would need to go and pull up that file to know exactly, but they do cover it. Any other questions? For those of you who want to refer friends, in a week or so, this will be available on demand for free again with CEUs. I want to thank you so much for participating and coming and joining me. My phone number and email address are on the screen. Please feel free to call me or email with me with questions. Email's probably better. I'm not always at a desk. And for more information on the Easy Stand and Zing standards, go to ultimatemedical.com.